And for our next session, which is Beyond Conventional Therapy, Standardizing Cholesterol Care and LDL-C Protocols for Policy Impact, which will explore how clinical practice, innovative therapies, and health policy can come together to create a measurable national impact. And for this, I would like to invite our speakers for this. Dr. Sandeep Bansal, Director, VMMC and Safdarjung Hospital. Thank you so much, sir. Dr. Praveen Chandra, Chairman, Interventional Cardiology, Medanta, Medicity, Gurugram.
So unfortunately, Dr. Praful Sharma could not make it with us today due to some unforeseen circumstances. We apologize for that. But we do have with us Dr. P. Ganesh Kumar, scientist and EN head for Division of Non-Communicable Diseases, ICMR NIE. I'll invite you, sir, to please join in. And this session will be moderated by Dr. Tina Raval,
Senior Research Scientist, Public Health Foundation of India. Ladies and gentlemen, please join us in welcoming our speakers for this panel discussion. Thank you, ma'am.
Dr. Raval, the job is yours to bring out the best out of this wonderful panelist now. It's all yours, ma'am. Thank you.
I must say, very, very difficult, because I think sharing a space with such a renowned, scientist and cardiologist, I think takes a lot of guts, what we have heard, I think, in the earlier session. So just to start with, I think we have been hearing since morning that India is, witnessing the surge in the cardiac episodes. It's not only in the elderly population, but among the young adults as well. And with the LDL emerging as not a silent but very, very critical risk factor. So despite of growing awareness, the management and the detection remains a challenge, especially what we have heard in this session also, that especially for the rural and the semi-urban sessions. So starting with this, I would request Dr. Sandeep Bansal. So if we are talking about the standardized protocol and policies, how does LDL-C contribute to the rising burden of the heart attack and stroke in India? Over to you, sir.
So I think that point has already been made. It's the major risk factor that has been already shown in several studies, including the Interheart, and we have a real burgeoning population of diabetics. So across the board, LDL is the major one. It's got causal relation, and there are n number of studies to show that if you bring it down, then you reduce the mortality also. Now, having said that, do we have a policy in place? Unfortunately, Government of India also does not have any recommendations as to at what age should you measure the cholesterol and how often should you repeat the cholesterol. We have, we've worked hard on diabetes and on hypertension. There was, so it is recommended that once you're 30, you should get your blood sugar measured and your blood pressure measured. And as Dr. Trehan was saying, how frequently to repeat, that will depend upon what your readings are. And in fact, the Government of India had launched a program called the 75-25, which basically meant that by the year 2025, India, we would have, detected 75 million people with diabetes or hypertension, and the government has been able to achieve that particular goal. But in terms of cholesterol, while we do have guidelines or recommendations from our professional bodies, the Cardiological Society of India, and there is a group of people who call themselves the Lipid Association of India. They all have their guidelines. So ideally, as per them, and this is actually in consonance with the standard American or the European guidelines, which basically say that once you're 18, you should be able to, you should at least measure your cholesterol and your lipid profile once. But we also need to understand India it's a different ball game altogether. We did some little work. We presented it at a place called EuroPrevent, which is the European Society of Cardiology's prevention program. We picked up 60 children, 30 in each group. These people were aged between 12 to 15. And the denominator was one of the parents had diabetes or hypertension in half of them, and in the other half, there was no diabetes or hypertension. And we measured everything in them, their metabolic parameters, which would mean their sugars, their lipid profiles, we did their echoes and their ECGs, everything. The values were still numerically within normal range, but they were significantly deranged as compared to parents who did not have either of them. Meaning thereby that in our country, we need to actually work up much earlier in terms of not just LDL cholesterol, but in terms of prevention of cardiovascular disease. In fact, let me go a step further. I'm taking a little time, but I think this is important. Let me go a step further. How many of us are aware of a national program which was called the Swasth Nari Sashakt Parivar? That was launched on the birthday of Prime Minister Modi. And see, the important thing is, if we have children with good birth weight, Dr. Praveen would be aware, I'm also aware, Aditya would be aware. We all in cardiology are aware of what we call as Baker's hypothesis, which basically says that if the birth weight is lower, then your chances of developing cardiovascular disease and diabetes in the later life are much higher. So prevention actually goes way beyond just measuring and treating LDL cholesterol.
Very, very valid point. I think it is much more scary. We need to be a little more aware, at the younger age. So I think not 30s, not 40s, but I think at the age of 18, when you are becoming in the area, in the league for the adults. So going into the next segment, Dr. Praveen Chandra, if I may ask you, what are the current challenges in helping patients to reach their LDL-C targets?
Yeah, it's a very important question, and it's a challenge actually for most of us, especially the cardiologists, because every day we are seeing more and more patients. And many times people come and talk to you and say, why the heart disease is increasing? And why we are seeing so many cardiac patients? Of course, awareness is one thing, early detection is the second thing, but definitely since morning we have been having this discussion that genetically we have this higher chances of developing heart diseases at a younger age. So as Sandeep also said that we have to start early, and the current challenge is that most of the times people have not done their cholesterol levels. So now as the recommendation goes, or as now the current knowledge goes, that everybody who is reaching the age of 25 years or 30 years must have a lipid profile done at least once at that stage. And if the lipid profile is within normal limits and if all the other risk factors are okay, then he should lead a early healthy lifestyle. But if it is high, then we have to bring it down. First, of course, by lifestyle measures, which most of the times people don't adhere to in the beginning. Like at 30, 35, 40, nobody will listen to any such advice. He says, okay, I'm so young, I will not have a heart problem. So that is one thing, the denial. The denial and not accepting that heart disease can strike. Okay? So only people become a little bit turbulent when there is some news that a young person had a heart attack, or somebody in the family, close family had this thing. So everybody will rush to the pathology lab to get a test done. And then we'll keep asking the doctor or a friend, मैं क्या कराऊं जा करके जिससे मेरे को पता लग जाए. So one of the easiest thing to do is get a blood pressure checkup done on a regular basis and a lipid profile test, as we are talking since morning, that cholesterol is one of the very important factors which lead to heart problem, and LDL is the target. And once we know that the LDL is high or is on the higher side, then we have to bring it down to a level which is recommended for different people, different levels. For example, if somebody has a heart problem or he is a diabetic, then we say that the level should be below 70 LDL. And many times you see it is above 80, 100, 120, 140. And what they will say, बोलेंगे मैं तो दवा खा रहा था, सब कुछ ठीक चल रहा था, I was taking medicine every day. But the problem is he was not taking medicine in a proper dose. Okay? So the first thing is that we have to tell, or we have to understand that the target has to be reached. Not only just the target is not taking medicine. The target is getting the LDL cholesterol down. Okay? So that is the target. So those people, जैसे किसी आपने, you must have heard that bypass surgery was done and then another angioplasty was done and he's still having heart problems, etc. So these are very high risk people. In very high risk people, it is actually a terminology, it is not my terminology, it is a well documented, it's a scientific knowledge. Very high risk individuals. Very high risk individual means he had a previous heart problem, he has a second episode, or he has additional diabetes and high blood pressure and has high cholesterol. In these people, the target is below 40. Okay? Now the question is, we understand that as cardiologists, so we write, okay, you take this dose, which is high dose. And then people don't accept that. They say, okay, this is too much for me, I cannot take this. And then they will speak to their family members or to some physician who is not so aware of that. He will say, okay, isko reduce kar do. Isko reduce kar diya to kya hua? He is taking the medicine, but he is not getting the benefit. So it's a false sense of security. So that is why this has to be understood, that we have to reach the target to get the benefit. Otherwise, there is no benefit. And there are levels now. The level 1 is that you lifestyle measures. Level 2 is, if it doesn't work, then you take medicines which are known as statins. And there is a very common misconception in society, in newspapers, in social media, that statins are the product of pharma companies and they want to sell it. Please understand, it is not true. It is absolutely false. Nobody is trying to sell it. It is for your own benefit. And they will say that it will kill the liver, it will create all kind of side effects, my memory will go, etc. That is not true. Statins are one of the best medicines for prevention of heart disease until today, and apart from aspirin. Okay? So statin has to be given to these people at a reasonable or high dose, whatever is recommended. Get the levels. If that also doesn't work, then there are second level of medicines, tablets which are now available. They can be given. Even if it doesn't happen with that, then there is a third level of treatment, which is those injectables, which I think Dr. Jain also mentioned. Those injectables can be given to these patients. They are, there are two types of injectables. One is once in 15 days, people can take a shot, and the second is a 6-monthly shot. You can take a shot, repeat after 6 months. So this is the spectrum of treatment which is available now, and if somebody has a target achieved, then the chance of having a coronary artery disease or another episode is minimized, deaths are minimized, heart disease is minimized.
Very, very important considerations. And you mentioned about the social media, which is very, very important factor now influencing the perceptions, especially with the public audience. So I think there is a need for strengthening the awareness where it comes from the point of view, like maybe from the cardiologist, that how the medicines are important and how it can be created as a public awareness, like a campaign which can generate, I think, and prevent, I think, the management or maybe the cardiac episodes. So coming to Dr. Ganesh Kumar, from policy and a public health standpoint, so how can India move towards a national framework that integrates LDL-C management with its NCD strategy? Over to you, sir.
Thank you, Dr. Rina, for that question. So I come with one experience which we implemented in the past 5 years, which is India Hypertension Control Initiative. When we started in 2017, when we went to the states and we found that none of the state has a treatment protocol. I mean, we have guidelines which runs in pages, 50 to 500 pages. But apparently, as a treating physician who is sitting in the primary healthcare center, or whoever is a private practitioner, who is a primary physician, they don't know where to start and where to switch over, the titration of that. So we introduced that hypertension linear protocol, which is on 3 drugs. We came to know that parallelly, what is the capacity at the ground level in order to treat the hypertension. We found that still it was far from the reality, even availability of a validated blood pressure apparatus was absent. Coming to this LDL-C, we successfully, during this particular implementation over nearly 26 states and across 180 districts, treating 51 lakh hypertension patients and 20 lakh diabetes patients. Our own data, we followed up of these 50 lakh and 20 lakh diabetes patients, less than 10% of them were under statins. We found that they are having high risk of that. Nearly 20% of them are having high cholesterol levels. Only a sample of them were only tested for that. We introduced including statins into the hypertension protocol and diabetes protocols in a couple of states. Out of the 26 states, only a couple of states have accepted it. There is a consensus guidelines recently which clearly said that any hypertension with a diabetes, start on statins, don't wait for doing a cholesterol level. If anyone who is having a diabetes more than 50 years with a history of smoking, start on statins. If anyone who is having an hypertension and more than 60 years with any one of the complications, start on statins. This has a very significant effect in terms of preventing the premature deaths due to cardiovascular diseases. We successfully introduced in West Bengal, that their policy, they have changed into the guidelines, into the protocol. At the start of the drug itself, like if you have diabetes, who is having a fasting blood sugar more than 250 milligram per deciliter, and a diabetic who is diagnosed more than 50 years and uncontrolled diabetes with the coexisting hypertension, and we need to immediately start on statins and don't wait for cholesterol level. Why I have been repeatedly saying that is, the parallelly we need to see 2 things. One, the capacity in order to understand all these guidelines and importance of starting the statins is very, very low. Number 2, we don't have that overall capacity of doing testing of cholesterol levels at the ground level. We have been seeing this very clearly. It's still segregated, maybe at the T2 levels, still going up to the ground level where huge amount of population is living. Access to the testing of cholesterol lipid levels is still low. With this, we tried in setting up the policy of bringing statins into the protocols. With this consensus, it's a recent publication in Global Heart Journal, which published in 2025. We came up with that, like including the statins into the directly in hypertension and treatment protocol and diabetes protocol. We need protocols and we don't need guidelines is one hard message that we have observed, and that way that we can take it further.
Very, very important points. I think we have just heard in one of the quiz which we just have conducted. I think we have been doing this cardiac surgery, I think, since 70s and 80s. Still, we are struggling with the protocols and the guidelines. So it's been more than 4 decades. So just over to, again, if I can just come back to Dr. Sandeep Bansal. So what are the current gaps in awareness, screening, and the guidelines or the protocol for the management of LDL-C, what we have been hearing? So what, I mean, still there are like policy gaps or how it can be addressed, if you can just highlight on those points.
See, yes, first thing is we need to come out with certain amount of policies. As I said, while we have recommendations from the professional bodies, they have not been endorsed at the governmental level for implementation in public. Our problem also is a lot of heterogeneity. We have we are a country which has several countries within it. So there's a lot of heterogeneity, and that's one reason why we are not able to have, universal recommendations. The third problem that has been highlighted already by Dr. Ganesh Kumar, who is going to have every population, every citizen of the country undergo the, testing of LDL cholesterol. Our pharma industry is extremely strong. Believe me, say almost close to 17 or 18 years ago, the government realized that the lowest hanging fruit in terms of cardiovascular management is what is done after a heart attack. So you're actually not causing a primary, get free drugs. And there are 4 categories of beta blockers, which are the 4th category of drugs. So we have a policy in place. Amitabh Bachchan, there comes the role of media and the social media. Understand that at the present time, in terms of the total health care, almost 60% is provided by the private sector. So the private sector and the government and the policymakers, everybody needs to, the recommendations or the things have to be very clear. At age 18, actually 18 is also very late. For prevention, you have to go to the school level. So in fact, I suggested to the government that at Safdarjung, we will adopt, say, 15 schools, which are there around Delhi. And 1 hour every month, the doctor's team goes and they talk to the children. They are quite recipient, they are, quite agreeable. They do listen to you, and they are the ones who are going to bring about the change. Then we also need to make recommendations in terms of, the family time. Everybody wants a me time now. Nobody wants a family time. So you have 5 people sitting, and the only exercise they are doing is with their fingers on the mobile phones. So we need to take care of all that.
Very, very valid point. I think it is very, very important to build the capacity of adolescents, maybe I would say, and as a change agents who can create, I think, not only at their school level, but at the family level and later at the community level. So it is important to inculcate those habits, healthy habits, which can be there at the school level. So maybe coming back to the Dr. Praveen Chandra, what roles do therapy choices, adherence, and patient education play in improving the outcomes?
Yeah, as I already said that, the challenges in therapy acceptance, of course, some of the myths which should be removed from people's mind in a very systematic way, because they have been put into their minds in a very systematic way, and for various reasons, through newspaper, through television, etc., that taking these medicines is dangerous. So it is important for people to understand that medicines are important if they are given for the right indication, especially as we are talking today of prevention of cardiac diseases and prevention of heart attacks, prevention of untimely deaths, young deaths which are happening because of cardiovascular diseases. In these people, because many times people will ask, there was certain news that suddenly somebody was very active, he dropped it. Why this happened? Could this have been prevented? The answer is yes. The only problem is that it never got checked, and even if it was checked, no action was taken at that time. And even if the advice was given, he didn't follow it because he thought that it is probably not so important to take that medication or do lifestyle change in his lifestyle. So for medications, for control of blood pressure, as Dr. Ganesh was mentioning, control of lipids, LDL cholesterol, stoppage of smoking, and of course other risk factors has to be done to prevent cardiovascular problems, because most of the times people are only taking medicines when they have a heart problem, when they are diagnosed to have a heart problem. The challenge is to start it before it happens. The challenge is to prevent a heart attack. So people sitting here, many people will have a heart attack at some point in time, because there is now an app which is available from the European Society of Cardiology. It is also freely available, and it is also available on the ACC. This is the American Cardiovascular Society, which is free app where you can calculate your 10-year risk or a lifetime risk of having a heart problem in future. That is very simple. We have to just feed 2-3 things. One, your age, your blood pressure, if taken once in life. Second is the cholesterol level. Third is the cholesterol level, and that's all. And also which part of the world you belong to, that's all. And it will give you a 10-year risk or a lifetime risk. And based on that, you can understand what kind of risk you have. So it is not something which happens suddenly to anybody. As people say that he was doing fine, he was running around and suddenly he dropped dead. Because nothing was done to prevent that at the right time. So prevention, as we are talking today, is the most important thing, and prevention will not only happen with just diet control and doing some yoga. It is also medications which is important if required, and we are not pushing medications, but we are saying that if it is required, please take it. And in proper doses, that is also very important, which people do not understand. And I am saying this again and again because this is a real problem. Because I am dealing with this, we are dealing with this problem on a daily basis, and most of the times, when after the heart attack, after 3-4 months, he'll say, oh, I have reduced the medicine because my family doctor said, probably you can now reduce it. I'm having some, weakness and things like that by taking this medicine. And I also read somewhere in the Google that it leads to liver problems or to mental problems, like, memory loss is also one very common thing which people say. So I think all those things have to be really removed from their minds, and to tell them that if you want to live another year or good many years of life, please take the medicines in proper dosages, and statins is one of the most important medications. There is nothing which will harm you in that. Of course, everything has a side effect which needs to be checked, and that is why it should be taken with the guidance of the physician or a cardiologist or whatever. So that is something which has to be kept in mind. And of course, the newer set of medications, the only problem is that the statins are now reasonably, I will say cheap, and many of them are also, if the generic version you buy, it is even cheaper, so it is not so expensive anymore. Although when actually statins started, everybody started saying, who can take this medicine? I mean, people would say that, why are you talking about this? This is such an expensive medicine. But now we realize it actually saves lives. So it is important to take it. The only problem with the newer medication, which is the injection, is that it is very expensive right now. It is costing about, I think, 1 lakh a year or something like that, 90,000. 1 lakh, because they are giving 1 + 1. So it is about 90,000 to 1 lakh a year. But certainly, if it is required to someone, he should know that this is something which is available. And we are fortunate, I must say, we are fortunate in India today that every technology is available for treatment, every medicine is available for treatment, and it is not that time, like, when we were very small, maybe in school, sometimes you would hear that there was somebody who is very rich and who is very influential, is sick somewhere, and some doctor is coming from abroad, or some medicine is being flown in for his treatment. It is not existing anymore. And also I must say that nobody is flying out of India for any treatment anymore, for any cardiac problems.
Agree, yeah.
My father got his angioplasty done in 1986 out of India because there was nothing available.
Yeah.
And today, nobody has to fly out of India for any cardiac treatment, whether it is bypass surgery or angioplasty or any medicine also. So that is a very fortunate situation. So we should take advantage of this and keep our society healthy as much as possible.
Thank you so much. And lastly, I think we have just covered the time, but maybe quickly, if I can ask Dr. Ganesh Kumar, what role data guidelines or the public-private partnerships play in achieving all this, I think, what we have been talking as a gap or the challenges?
I'll take a very quick. First time when we data, why it is very important in order to first marry that particular problem. In 2017, we conducted NCD monitoring survey. First time we came to know that nearly 70% of the high blood pressure are unknown. Number two, less than 1 in 10 of those people with the high blood pressure are under control, which says that 90% of them are uncontrolled, leading to heart attacks and stroke in the future. Number two, first time we generated a data about the unavailability of the drugs. First time we introduced hypertension protocol drugs in many of the states. Many states have procured for the first time in this during our implementation. Third important data is that follow-up of these patients. What we found is that over the follow-up period, what we could achieve, we could have demonstrated it. In 2017, when we did a baseline survey, the unknown hypertension was nearly 50% in 9 districts. And in 2024, when we completed the survey, we found that it has reduced to 45%. The control rate has increased to nearly 8%. What is a low-hanging fruit we came to know is that there are people who are aware, but they are untreated. There are people who are aware and treated, but they are uncontrolled. The same goes for LDL also. We found that huge amount of them were untreated and they are not having a good metabolic control, which has the LDL component into it. I'm very happy to hear that from the cardiologist and the cardiothoracic surgeon, that because there's a huge amount of a myth around the statins, and a huge amount of the myth around even taking blood pressure drugs and oral hypoglycemic agents. We need to demystify all those myths together. A good capacity building, and of course we have come up with a strong policy to include into the protocols. All these things favors public-private partnership. The most important part is that we share a lot of common learnings, cross collaborations. The true scale only when it comes when there is a collaboration between public and private partnership. That's what I want to say.
Very, very important points. I think what has been come up as a major recommendation from this discussion, translating the evidence-based, I think the data, it's require an integrative approach where we can have a contextualized actions and the guidelines which can be adopted at the national level. But I think at the same level, there is need for a joint efforts, not across the stakeholders, I would say maybe at the policy level, at the clinical level, but also at the measure where we can build the capacities and can have a task shifting where we can strengthen the primary care, and especially at the rural and the semi-urban areas. So with this, I think it is very, very important when we have a monitoring system creating a coordinated and sustainable framework for an effective cholesterol management at the national level. With this, I would like to thank all the panelists for their, please, I think maybe if we can just quickly have questions, please.
You asked for the regular health checkup is a very good point, and we have to follow your guidelines. My two questions, if you allow me to ask you, do variable devices help in real time detecting the issues, medical issues? There is one question. Second question, you asked for the medical checkup. The question is where to go. There are more than 3 lakh diagnostic centers, labs are in India, and hardly not even 10%, if you allow me to say, not even 10% are being accredited with the NABL, because it is voluntary and not the mandatory. So there should be some law to restrict, stringent conditions should be there that they have to be registered with some regulatory bodies to maintain the standard. Thank you.
So, NABL accreditation at the present time it's not mandatory. It is, recommended, and it has to be voluntary. What can the government do? What the government can do is, if you are NABL accredited, you get higher payment as compared to those who are not NABL accredited. And if you look in the government recommendations now, that has already been done. If you look at the CGHS, the Central Government Health Service recommendations, there are differential payments for NABL and likewise NABH accredited hospitals versus those who are not. Okay, and that spreads across the board. That spreads not just in A category towns, but also in B and C category towns. So there is a differential payment. That is how it can be. You make it mandatory to become NABL accredited place, the pathology labs themselves are going to say that they don't have, I mean, so that particular answer is pretty clear. Star ratings are also going to come in place. Gradually, star ratings are something which are harder to implement. You know, they are harder to implement, and that's the reason there is a little bit of an issue in that. Now, having said that, the second part was wearables. The wearables, they have been, my friend Anil Saxena is there. He's an electrophysiologist. Aditya is also an electrophysiologist. So, while there is a lot of, you know, the cost to benefit ratio in terms of wearables doesn't come that way. Wearables, I mean an Apple Watch or something like that, which can determine your arrhythmias. Multifunctional wearables are still not there to a large extent. Say the Apple Watch started a arrhythmia detecting kind of thing. Almost 5.5 lakh people they put on in normal population. So the pickup rate, the number of people who came out with treatable arrhythmias is very, very small. It's very, very small. So the cost to benefit ratio at the present time certainly does not come. We are not talking of secondary prevention again. There are some wearables, ambulatory, ECG recorders, and we have long-term ECG recorders, long-duration ECG recorders. Those are different. Those are different wearables. So we are not talking of that. So on population basis or recommending on a general population basis, wearables cannot be recommended. And the third thing, the executive checkups. They have been more hyped than, they have benefits. I'm sure Aditya would agree with me on that. If you are, because we come from a similar background, we come from a public hospital. So if your blood pressure is all right, if your sugars are all right, and if your lipids are all right, by and large, you don't need anything more. There's a burgeoning population of people with chronic kidney disease, so one might add renal functions to that. You don't need fancy tests. You don't need calcium scoring for every single soul. So you build up on that and you encourage your people to keep these simple things normal. On an individual basis, I'm very anxious about myself. I'm a young chap. I want to know what will happen to me. That's a different category. But on population basis, we've been talking on what the government should do or what the government should recommend. The simple things are good enough to keep you fit. There's no need to undergo. I mean, people come up with the stupid observations, as I see in the OPD. My doctor has said you have to get a treadmill test done every year. I mean, bureaucrats come to me, IAS officers, who say such and such person said the treadmill has to be done every year. Some will even repeat their nuclear scans, not remembering that they're getting radiation. So the actual basic things are very simple. On a population basis, only those can be recommended. On an individual basis, it depends upon, how much one wants to look into oneself. But also remember that trying to detect what is not there or what is not obvious is something that is going to cause you more anxiety. There's another group of people that we see now who are called cardiac neurotics. The doctor did not find anything in me, so we went and did this advanced test. There is a tiny fault in that. Can I die because of that? I went for the executive checkup. My treadmill is positive. My doctor is saying, we don't take your guarantee once you move out of the hospital. So you get your angiography done right now. We don't take into consideration our informed decisions.
Sir, can I please interrupt?
We can talk.
Your questions are very powerful and they are generating a powerful response. But the time is really, no sir, I have to unfortunately stop this. Please, Dr. Bansal is going to be addressing another session after this. We don't want to drain him completely. Thank you so much, Dr. Raval, for really bringing out the best. And thank you, sir, for bringing out such insights from Dr. Bansal. I'll invite you to please hand over a small token of our gratitude to our panelists here. Please, ma'am, starting with Dr. Bansal. If you can hand over this to Dr. Bansal, please.
Let's have a round of applause for our speakers for this amazing discussion. Dr. Praveen Chandra. Dr. P. Ganesh Kumar. We were expecting Dr. Praful Sharma. We wanted him to be here.
And if I could please invite Dr. Nishchal to step up and hand over a memento to Dr. Raval here for bringing out the best in the panelists here. Thank you. If we can all be together for this group picture. So, ladies and gentlemen, in the interest of time, we unfortunately had to cut this short. And of course, so much insight that came under this particular session. But we promise you that there is much more lined up for you today. Thank you. Thank you, ma'am. Thank you so much.